it looks like the residents are in the resident room too, so.
Oh, perfect. Okay. Well, then let's get started. So we continue on with, good morning, everybody. Dr. Williams is at an alternative meeting. As we continue on with Prostate Cancer Month, I believe our intended speaker had a sudden death in the family and so won't be able to be here today. So Dr. Gerard has agreed to pitch hit and do a lecture for us, and then we'll be followed by Journal Club. Is that in a separate session, Dee, or the same? So we'll just be staying in the same WebEx for the whole time. Without further ado, Dr. Gerard.
Well, thanks. Yeah, so I first of all, obviously, apologize in advance. Shane Wells had a really nice talk on imaging. We'll work that in later in the year. But what I was going to plan to do today is talk a little bit. You've heard a lot about prostate cancer. We've reviewed sort of advanced prostate cancer. We've talked about active surveillance. And what I was going to plan to do here is just shift gears a little bit and dust off a talk I'd given a couple of years ago at the North Central, really looking at sort of an introspective look at why we haven't cured urologic cancer. And I think this is especially pertinent right now. This December 23rd actually marks the 50th anniversary of Richard Nixon's signing of the National Cancer Act. That was in, I think, 1971. And, you know, I know that as we approach that date, there's going to be a lot of questions. You know, why haven't we cured cancer yet? Or why isn't our war on cancer over? So I thought that, and indeed during my career, I never thought that we'd sort of get to this point where we haven't really cured prostate cancer. So we've definitely made progress, but it's much like the layers of an onion. You peel off one layer, solve one issue, only to discover a more daunting one. So I hope you'll bear with me today, and we'll spend some time talking about this issue. These are my disclosures. So we've made progress, and there's been a drop in prostate cancer deaths by about 45% over the last 25 years. This is not all rosy. Many patients actually subsequently fail therapy and go ahead and die of the curve, but die of this disease. But there's definitely been a decrease in the number of cancer deaths. Part of that's due to increased screening. You can see that across the board with many cancers. And in the top left, prostate cancer is represented by this brown line. It was back in 2008, 2013 that the U.S. Preventative Health Services Task Force really recommended against routine screening. And what we noticed as in the 2010s was that there was a flattening of the curve. Indeed, mortality rates began increasing in many subgroups. So this has led to concern about cancer and the way we're screening for it. And how much of that was actually of our ability to cure patients is actually dependent on detection. And I would say probably at this point in our progress, a significant amount. So we've definitely made improvements in technology. And this is a slide that I'm going to click through here. Some issues. Slide looking at New York Times in 1987. Was talking about sequencing the human genome, and clearly being able to look at all of the alterations in a tumor has given us a clearer understanding of how to cure these cancers. But back in 1987, the New York Times said today only about 500 human genes, less than 1% of the total, have been decoded. Even a steady rate in the rise of sequencing would leave the job unfinished until the 22nd century. And lo and behold, there were a number of marked advances. And if you look at actually how long it took us, let's just back up here. Yep. So it was actually 2001 when the first sequence was performed. Cost about $100 million. This is through the National Cancer Institute. And if you look at the cost of sequencing a genome, this really sort of follows Moore's law. And Moore's law it refers to an observation made by the Intel co-founder, Gordon Moore. It was back in the 60s. And he was basically looking at transistors and integrated circuits in computers and looking at how quickly the ability to process changed. And Moore's law predicted that there's a trend, a steady state trend where cost will decrease over time. But what you can see from this, and this applies to the cost of sequencing a genome, is that it's remarkably, it's much quicker, the decrease in cost. And this represents a lot of new technology that's been developed. And indeed, you can sequence a genome for less than $1,000 now. So this represents a lot of new technology that we've developed. We've also seen a lot of advances in our ability and technology. And it was really 2001 when the first robotic prostatectomy was described. It was actually in Detroit. In 2004, about 15% of the prostate removals were robotic. By 2009, it was over about 85%, and then today it's greater than 90% of prostate removals are robotic assisted. So this is again been the rapid development of technology has led to this growth in robotic prostatectomy. And obviously, prostatectomy is really a proxy for this larger debate about cost, technology, and innovation in medicine. This is one of the billboards from about 10 years ago, and I always look at this and think perhaps maybe urologists are not the most humble physicians. Okay, so I wanted to think about some of these questions over the next few minutes, and regardless of what sort of practice you have, I think it's worthwhile looking at this larger picture for a few minutes. Some of the questions are, why are we struggling in this war on cancer? What really causes and how do we prevent cancer? And what can we do to better detect and treat urologic cancers? And what I'll be talking about is heterogeneity of cancer, so maybe some strategies for overcoming that. We'll talk a little bit about cancer development, but how this may give us clues to how to prevent cancer. I think there's a massive need for better biomarkers. And I think also just this whole need for us as a field to support research will be important. So this is really one of the more depressing studies I've come across. And this is actually a couple of my colleagues here, Glenn Liu and Robert Uri, here in the Cancer Center. And this was actually a patient with a PSA of 160 with advanced metastatic prostate cancer, who was treated with enzalutamide, androgen signaling inhibitor. He was actually imaged with sodium fluoride PET. Now, this looks at sort of metabolic activity of these lesions. The PSA dropped all the way down to 11, so he had a very good response to this. And what they did is they actually looked at individual lesions, the intensity to measure the metabolic activity of each lesion. And what you can see here is that on the left, there were a number of lesions that respond, and that's shown by these green lesions. On the right, however, there are a number of non-responding lesions. So here's a patient, PSA dropped significantly down, but there were, and when looking at this patient, one would think, well, we've done a great job with this patient, he's improving significantly. But what you see here is that on the right, there are these red lesions, which again represent those non-responding lesions. So this really suggests this sort of macro metastatic heterogeneity that you see between lesions with enzalutamide. And we actually have a study on our SPORE grant looking at treating those non-responding lesions to again see if we can improve better outcomes. And we're going to be doing that with radiation therapy. But this again gives you a clear visual sense of some of the problems, major hurdles we have with regard to prostate cancer treatment. This is moving away from prostate for a moment. This is actually a study that is from a number of years ago, but it really represents to a certain extent what's been done very frequently after this point. And this is actually looking at sequencing of individual biopsies in a kidney tumor. What you see here is this is looking at all different biopsies from different areas within the kidney tumor. They then looked at different metastases as well. And what they actually performed exome sequencing, chromosome alteration analysis, and ploidy profiling on all these separate biopsies. And the really striking thing about this study is that when you look at, and this is shown at the bottom here, when you look at each of these different biopsies and metastases, it's only about 70% of somatic mutations are not really detectable across all tumor regions. So when we're thinking about trying to treat prostate cancer and come up with a driver mutation, again, one of these alterations that can be targeted and found in virtually every cell, it's very difficult to do. The other thing about this is obviously if you're looking across all of these different biopsies, depending on where your biopsy, you may get a different answer. Again, representing some of the issues. We see this in prostate cancer and other cancers as well. So this issue of heterogeneity is a major issue. And there's this driver alterations that generate a target are not found very frequently. But personalized medicine approaches are likely to improve this. And that's why there was a lot of enthusiasm when we talked about this issue of BRCA, germline BRCA, and other DNA repair mutations in advanced cancer, because those tend to be found in each of the cells. You can treat these individuals with these PARP inhibitors and lead to a significant response in many of these individuals. So I do think that we're making progress in this area. Another issue with heterogeneity is this aspect of emerging resistant subclones with continued drug exposure. We'll talk a bit more about that. And then finally, when you look at the cost of care, between 2002 and 2012, there were 71 anti-cancer drugs approved by the FDA. The median overall survival benefit was about 2 months for patients. And it's estimated about $10,000 per month on therapy at a cost of $2.7 million per life year saved. So cost is an issue as well. And clearly, as we move forward, it needs to be something that we think about. So how do we overcome this heterogeneity? Well, one is to target these dominant truncal drivers, these clonal that give rise to these clones. Another is to really shift our focus from attempting to eliminate cancer cells to controlling cancer. And it's interesting, we all know that therapy tends to select for resistant subclones. This picture on the right is looking actually at diamondback moth. And this is a moth that's found in the Central Valley. A number of years ago, they used to treat this moth with, it feeds on the vegetables and fruits in this area. The larvae have about a 2-week lifespan, so it turns over very rapidly. And these moths become resistant to pesticides very, very quickly. So it's interesting because what they've done, and there's a whole field of studying this aspect of therapeutic selection. They've actually sort of changed the strategy, and instead of trying to get rid of every single moth, they actually leave a large population present to compete with the resistant ones, and they use these pesticides in a very different manner rather than trying to get rid of every cancer cell. Just sort of suppress the population. So this is one way to think about one therapeutic strategy is maintaining tumor volume, but suppressing cells. And this has actually been looked at in ovarian cancer, where you've used chemotherapies that are really optimized to maintain stable tumor size versus some of the high-dose chemotherapy that selects for these resistant clones. So I do think, given this, that surgery still plays a role in cancer management. We're very interested in this whole issue of neoadjuvant treatment, whether you can, improve outcomes with combining chemotherapy treatments and then removing the resistant cells. And one other final aspect of this is coming up with strategies to make tumor cells look more alike. And this is really one of the exciting things about immune-based treatments, is there seems to be more common expression of a lot of these neoantigens in these tumors. So immune-based treatments have really, for many cancers, some, for example, some renal cancers, some bladder cancers, there have been remarkable responses with some very advanced prostate cancers as well, and melanoma. These immune-based treatments are really very exciting. I was going to talk a little bit about some work we've done here, looking at androgen deprivation therapy and whether it may introduce some consistent changes in these tumors to make them look more alike. So this is Dr. Charles Huggins. He was one of the two urologists who won the Nobel Prize. And this was really based on his discovery of the endocrine sensitivity of not only prostate cancer, but breast cancer. He actually was at the University of Chicago, and I hadn't met him when I was there. He used to come in even when he was in his 90s, promptly at 9 o'clock every morning. Really a remarkable individual, and his pursuit of science was really legendary, what he actually did. He also sort of coined this term, well, he said that science was the art of the 20th century. I would point out also he was a member of our section, the North Central section, as well. But remarkable character, and really someone who has really changed the field of cancer therapy. So when you think about androgen deprivation therapy, when we treat tumors, if you look on the left here, there is the killing of these sensitive cancer cells, but there's still a significant amount of cancer that is left. And these cells, there are resistant clones there. There's cells that have stopped growing, some that have become what we term senescent. And those will actually grow out over time and be able to bypass these resistant mechanisms. We've been able to, through a number of studies, I was involved in the CHAARTED hormonal therapy trial, which actually looked at chemotherapy with androgen deprivation therapy to get rid of these resistant clones. But we also did another study, and Dr. Richards and myself and Vince Crines in endocrinology looked at this. We've published some research out of the lab based on this. But if you look at metabolic drugs, they can actually target these cells after treatment with androgen deprivation therapy. So these cells actually will sit there, are metabolically very active. And metformin actually improves cancer-specific survival. This is looking on the right at a population of veterans. And this is about over 70,000 veterans who were placed on androgen deprivation therapy for prostate cancer. And what you see here is that the non-diabetics are this population here with a blue line that were not on metformin. You can actually see that diabetes without metformin, there's actually a slight protective effect. And then finally, the group that actually did the best was the diabetics who were on metformin. So metformin led to a marked improvement in cancer-specific overall, as well as metastasis-free survival in these patients. So this was really a very striking finding. and is worth certainly further study. And that is ongoing at a number of other institutions. So this study is a study that I was very influenced by, and it really talks about this issue of just the bad luck of cancer. And as humans, I think we always look, and I can't tell you the number of times patients have come into clinic and said, doc, what can I do to help prevent cancer or to improve outcomes? And this is really looking at how much of cancer is due to chance and how much of it is due to actually environmental issues. And what they did here is they did a lot of calculations looking at the number of stem cell divisions for a cell. And basically, you can correlate the number of stem cell divisions with the lifetime risk of developing cancer. And you can see this pretty clearly. And this is a number of different cancers. And these are very small writing here. I would say they didn't look at prostate cancer, which was unfortunate, but what they found was that errors arising by chance during the cell division explains about 2/3 of the reason that adult cancers divide. So you can essentially say that about 2/3 of cancer just arises due to bad luck and aging, if you will, and about 1/3 due to environmental issues. So this is again another way of thinking about prostate cancer and other cancers. So one way of, however, of decreasing stem cell prevention is, and I've often thought that this was data that is probably overlooked. We've known for a number of years there were two very large trials, the PCPT and the REDUCE trial, looking at finasteride and dutasteride for prostate cancer. There was about a 24 to 18% reduction in risk of cancer at 7 years. You can see here on the right-hand side how these separate. These were patients that were placed on these drugs and then biopsied routinely throughout over time, over the course of about 6 years. And so here was a trial in which patients were placed on a drug that had very few side effects. It even improved your outcomes, and it reduced your risk of developing cancer. So I think given this data, this is probably some data that is underutilized. There was a subpopulation, and I'm certainly aware of this, of patients that had increased grade cancers. There's been a lot of debate for why that occurred, but it was a very small subpopulation. And I do think that moving forward, chemotherapy needs to be a focus of we as urologists, and we need to think about what we can do for our patients with regard to not just treating these cancers once they develop, but also preventing them. So Albert Einstein said, we can't solve our problems with the same thinking we used when we created them. And I think this is quite applicable to this issue of screening. Now, the data from SEER would really suggest that we're not really screening very well. And if you look back a number of years on the left here, this is looking at screening for patients. You can see one of the remarkable things about this figure is the number of patients that are over in their 70s who are screening for prostate cancer. These are the individuals who are less likely to benefit from PSA screening. And one advantage about this whole issue of controversy with PSA is there's been a decrease in PSA screening and biopsy in that population. But what we have seen over this past period of time is that there was this initial decrease in distant disease that was detected, and now there is an increase. So clearly with this approach towards decreased screening, and this was about a 30 to 40% decrease in PSA use. We saw some flattening of the curve and increase in mortality in patients due to prostate cancer associated with this. So this again suggests maybe we're we shouldn't necessarily decrease screening for all patients. We should just be more selective. And this, again, emphasizes this issue of selectivity in who you're screening. And we spend a lot of time in clinic talking patients out of PSA screening. Another aspect is when we develop biomarkers, they have to add value to our clinical modeling. And this is a prime example of a biomarker that doesn't really add much value. So this is actually looking at patients on active surveillance and looking at the 4K score, which is a series of PSA and kallikreins. And what they did is they looked at individuals as far as predicting outcomes with the initial biopsy. And what you can see here is if you added just clinical pathologic features or you looked at those features plus the 4K score, there was really very little difference in the ability to detect cancer. And this is looking at area under the curve, which is a measure of sensitivity, specificity. What you see here is that for subsequent biopsies, it was really there was really no difference at all for subsequent biopsies. So again, we have to look carefully at the way these biomarkers are presented. And that's why I'm typically not a huge fan of the 4K score and the PHI, the prostate health index, which is another blood test. It's just not been able to really move the needle to a large extent. And because another aspect is we're not really able to achieve an area under the curve of 0.8. And really that's a major question right now, is that seems to be a ceiling when it comes to biomarkers and improving outcomes. So I do think the PSA is not the answer, and we're desperately in need of better biomarkers. And I'd point out the 4K score and the PHI score are both PSA based. I do think urine is a gold mine, and there's some really interesting data coming out looking at exosomes and short RNAs, hairpin RNAs in, or short RNAs, siRNAs in these individuals in the urine. There's a lot of enthusiasm for biomarkers in the field, but very little validation. And what often happens is these markers come out, they look great. We apply them to the average patient in Black Earth, Wisconsin, or Richland, and the ability to detect cancer or the performance of these biomarkers really decreases once you get it out in the community. So that's one important thing with biomarkers we need to ask ourselves is, does it impact management? So the final thing I'll just mention is this issue of the loss of the research workforce. This is looking at physician scientists. And what you can see here is looking back over the last 10 years ago. This was a paper published a number of years ago, and this erosion continues to occur. And there's been a real flattening of the number of NIH research projects candidates over time. And you can see here that this number really has not changed. And furthermore, when you look at the number of individuals, young individuals and mid-career individuals that are able to continue in research, you can see there's a marked decrease in the number of physician scientists. So this is, again, something that we, as urologists, and I'd like to encourage all the residents to think about involvement in this kind of area. There are a lot of opportunities with regard to clinical trials and helping translate research findings from the clinic to the bedside. So another aspect is why spend these research dollars? And I do think urologic research can help improve patient care. There's evidence to suggest that it improves our specialty and certainly justifies its existence. Charles Huggins is a prime example of that. It does promote prestige for the field and philanthropy as well. Patients like to hear about advances in cancer and other fields. And I think also it's important for faculty development as well as resident education. So something to think about as you move forward in your careers. So what about, I'll just sort of sum up here. And I do think we're up against a real challenge. But I would say that one thing attracted me to urology was the fact that I think of us as being a very innovative a bunch of physicians. And if you look at lasers, robotics, shockwave lithotripsy, a lot of the newer drugs, and there have been 14 drugs that have been developed for advanced prostate cancer now. It really is a very innovative group that's involved in urology. But there are these major hurdles that I outlined, heterogeneity, resistance, and detection. I do think moving forward that urologic surgery is going to continue to play a role in the treatment of patients, even with advanced cancers. I do think also that we need to be very supportive of research, clinical trials, and obviously education. And then finally, and this is again just a call to action, we do need urologists to continue to be involved in research. Whether you're at an academic institution, you can contribute even from a private institution, and especially for the residents, we do need urologists that continue to be thought leaders and innovators. And urology is really, I would say, blessed by attracting the smartest, really, of the physicians. It's one of the most competitive fields to get into, and I think that moving forward, the future looks very bright. So I'll stop there and certainly take any questions. I'm just gonna end with a slide here. So just family, just in Don Coffey, who was a mentor of mine a number of years ago. Had actually died in 2017, and he was really somebody who said the most honest, most important ingredients with regard to both research and clinical work is honesty, desire, clear thinking, confidence, and most importantly, hard work. So I'll stop there, and thanks for your patience. Sorry this wasn't about imaging, but maybe this stimulated a little thought with regard to the field and what we're doing in general. So thanks.
Thank you so much, Dr. Gerard. That was a fantastic talk. I'm just, if you have any questions, please, everybody submit them in the chat if you can, and I will also, Dee and I will look for raised hands. Dave, what do you think are if you are a young person starting out in urology, how do you get into research at this point? Clearly, there must be barriers.
Yeah, and it's clearly there's more of a challenge when it comes to academic institutions supporting research. I mean, dollars are getting squeezed, and so it makes opportunities, and I would say also that training is becoming more streamlined. Part of it, I think, just begins with having interest in a question, coming up with a question that you're interested in. We have a lot of great faculty here that if you talk about that question with them, they can help develop it. I know that there are a number of residents in the group that are working on questions that they're interested in. So that's one thing, is just thinking about, I think one of the unique things about us is that you see a patient in clinic, and that really stimulates how you think about the disease, and it leads to questions that you can then look at either from a standpoint of a lab-based study or even a clinical-based study. So I encourage the residents to be creative in how they think about things, approach faculty about questions that they have an interest in, and we know it's a requirement of the residency program to be involved in some research projects. It gives you an opportunity to go to meetings, and obviously not many meetings in the last 18 months, but moving forward, it should.
We have a question from Dr. Tierney. How much do you think our prostate biopsy sensitivity plays into the 0.8 area under the curve ceiling? And then do you think MRI fusion will help to improve that?
Yeah, no, that's a great question, Adam. And it has improved our ability to detect higher grade cancers. But one of the interesting things about MRI is that it's not perfect. If you look at large studies that have imaged patients before and after the prostate's removed, it misses about a third of significant cancers. So I do think MRI is playing a role. I think, like anything, there's a pendulum that swings back and forth. And right now, there's a lot of enthusiasm about MRI, but what we're seeing is some papers beginning to come out showing its shortcomings. I do think down the road, though, there is going to be better imaging that is going to really help us much more significantly. And this is right now, it's available, PSMA PET imaging, but it needs to be applied to the prostate in a way that you can look at individual lesions. And we actually have a PSMA PET MRI device here, so you can look at individual tumors within the prostate that light up. So to answer your question, yes, biopsy is playing a role in our inability to detect these cancers. I do think MRI helps some, especially in the rebiopsy setting. In the future, there's going to be better imaging to help us even more.
And then another question from Dr. Taze. Can you please comment on your use of biomarkers, if at all, in your clinical practice, given your comments today?
So I do use PSA, free to total PSA. I'm, again, somewhat hesitant just from a cost standpoint to use some of the other developed ones. There is some excitement with a couple of these urine-based tests, and I think that I would keep an eye out for Exosome DX, which is a urine-based test. I'm not using it routinely here, but that is, I think, an interesting marker. I think the urine makes a lot of sense. With regard to, and I don't want to necessarily plug any specific genetic test, but I do use the Oncotype DX. Again, there are a number of these tests, Decipher, in patients that I'm considering for active surveillance in certain selected situations when the answer is not clear or the patient needs additional reassurance with regard to active surveillance. Or the other option is sometimes patients, you can't talk them into treatment even though you need it. And in those kinds of situations, I'll use genomic testing. So from a localized cancer standpoint, that's important. And when we talked the other day, Dr. Kyriopoulos, no, actually, it was David Kosoff talked about the importance of biopsy. And clearly, when you have patients with advanced disease, biopsy plays a role in directing therapy.
Thank you. Any other questions? I don't think I see any raised hands. All right. Well, thank you again for sharing that with us and for sharing it at such last minute notice. We're going to move on within this